Doctors, welcome to today's explainer. Dekha dosto, I know anatomy can sometimes feel like a massive maze, but today we're going to make it incredibly simple. We're not just going to memorize a boring list of names for the upper limb blood supply. Nope. Instead, we're going to treat it like a high-speed highway that we're road tripping down together. So focus up and let's master these vessels.
Now, to crack exams like NEET PG, structure is absolutely everything. बिना structure के recall करना मुश्किल हो जाता है. So here's our exact roadmap for today. First, the upper limb blood highway. Then, the axillary artery and its anastomosis. Third, the brachial artery and clinicals. Fourth, forearm and Palmar arches. And finally, the Allen's test.
Section 1, the upper limb blood highway. I want you to close your eyes for just a second and imagine blood flow as a road trip, starting all the way up in your chest, rushing right down to your fingertips. The most interesting concept here is that we are literally talking about the exact same pipe. A key blood vessel hai, it just changes its name as it crosses different borders. It starts off as the subclavian artery, but the moment it crosses the outer border of the first rib, boom, it becomes the axillary artery. Then, as it passes the lower border of the teres major muscle, it's newly crowned as the brachial artery. Finally, down at the neck of the radius, it bifurcates into the radial and ulnar arteries. The Knack, memorize these specific landmarks right now. The first rib and teres major are super high yield for MCQs.
Just follow that red highway. You can see the subclavian artery emerging right near the scalenus anterior muscle. As we trace it down, it crosses that dotted line, which is the first rib, and suddenly we're in the axillary region. Continuing down, past the teres major, it enters the arm as the brachial artery. And right there at the bottom, near the elbow joint, you see it splitting into the ulnar and radial branches. Concept perfectly clear, right? Let's keep moving.
Okay, यहाँ ध्यान से सुनो, because direct questions आते हैं इस topic से. The axillary artery is divided into 3 parts by the pectoralis minor muscle. And the rule of thumb here is just beautiful. Part 1 has 1 branch, Part 2 has 2 branches, and Part 3 has 3 branches. Now I want you to focus heavily on Part 2. It gives off the thoracoacromial artery. You absolutely must memorize its 4 divisions using the mnemonic APCD: acromial, pectoral, clavicular, and deltoid. Mark my words, do not forget APCD.
Section 2, axillary artery and scapular anastomosis. Now, what happens if there's a roadblock on our axillary highway? Maan lo ki proximal axillary artery block ho gaye from trauma or a clot. Does the arm just die?
Well, nature is much smarter than that. Enter the scapular anastomosis. This is a collateral network between the branches of the subclavian and axillary arteries. Basically, ye nature ka apna backup route to save the limb from ischemia. The blood simply takes a detour around the block via the scapula and rejoins the main highway further down. Now, please don't just blindly rote learn this list. Try to actually visualize it. This anastomosis happens at 3 distinct bony landmarks on the scapula. First, at the acromion process, we have the suprascapular, the posterior circumflex humeral, and the acromial branch meeting up. Then, on the body of the scapula, it's the dorsal scapular, circumflex scapular, and suprascapular. And finally, down at the inferior angle, the dorsal scapular from the subclavian system meets the subscapular from the axillary system. Notice how subclavian branches are constantly shaking hands with axillary branches.
And this beautifully illustrates that exact handshake. Notice the complex collateral web going on here. Look at how the branches from above the block, like the suprascapular artery coming off the thyrocervical trunk, communicate with branches below the block, like the circumflex scapular artery. Picturing this web in your mind is going to seriously solidify your spatial memory and help you eliminate those tricky wrong options in the exam.
Moving on to Section 3, brachial artery and clinical aspects. All right, we've successfully made it past the shoulder. We are now entering the arm, the domain of the brachial artery. And this is where we get into some of the absolute most crucial clinical applications you'll ever face.
Follow that major pipe running straight down. That is your brachial artery. But see that branch peeling off and diving backwards? That right there is the profunda brachii artery. It runs in the spiral groove of the humerus right alongside the radial nerve. Hamesha yaad rakhna. The profunda brachii and the radial nerve are travel buddies in that spiral groove.
Guys, listen up. This is a massive NEET PG trap. When we talk about a supracondylar fracture of the humerus, examiners absolutely love to test your applied anatomy. Students so often wrongly pick the median nerve as the most commonly affected nerve. But look at this exam pearl carefully. The most common nerve affected is actually the anterior interosseous nerve, which is a branch of the median nerve. So mark this in your brain right now. AIN is greater than the median nerve in this specific fracture. Concept clear? Awesome.
Now, let's look at a much more serious clinical scenario. मान लो supracondylar fracture में brachial artery cut हो गई या severe compression हो गया. What happens? Ischemia. The muscles of the forearm are completely starved of oxygen. They undergo necrosis and turn into fibrotic tissue. This leads to Volkmann's ischemic contracture. You get a severe, permanent claw-like deformity of the wrist and fingers because the flexor muscles have literally contracted and died. It's a devastating consequence that we have to act incredibly quickly to prevent.
Next up, Section 4, Forearm Arteries and Palmar Arches. Let's keep moving down the highway. We've navigated the arm, and now we shift our focus to the destination of our journey, the forearm, and the intricate network inside the palm of the hand.
So the crucial point here is right at the neck of the radius, where the brachial artery divides. Look closely at the ulnar artery. It gives off a very important branch called the common interosseous artery. This common branch quickly splits to hug the interosseous membrane. One goes anterior, one goes posterior. And notice how the anterior interosseous artery actually pierces the membrane distally to join the posterior side. It's just a beautifully efficient routing system for the forearm.
Now we finally reach the hand, where the radial and ulnar arteries join forces once again to create the palmar arches. This is a classic comparison for exams. Ik simple trick याद रखो. The ulnar artery is mainly responsible for the superficial arch, while the radial artery dives deep to primarily form the deep arch. Plus, logically, the superficial arch sits more distally in the hand, while the deep arch sits more proximally. So ulnar for superficial, radial for deep. Super simple, right? Which brings us to Section 5, Clinical Relevance, specifically the Allen's test. This is a direct, practical application of the palmar arches we just learned about.
Before you ever puncture a radial artery to draw an ABG, an arterial blood gas, you must perform this crucial bedside clinical skill. Let me walk you through the procedure step by step, just like we're on a ward round together. First, you ask the patient to make a very tight fist to squeeze all the blood out of the hand. Second, apply firm pressure with your thumbs on both the radial and ulnar arteries at the wrist. The hand will turn pale or blanched. Third, while the patient opens their hand, you release the pressure on one side only, let's say the ulnar side. Finally, you just observe. If the palm flushes and turns pink within a few seconds, it means that ulnar lifeline is totally patent and functioning perfectly.
Let's compare the visual results side by side. On the left, we release the ulnar artery, but the palm remains blanched and pale. This is a negative modified Allen's test. It means the ulnar artery is not patent, so if you were to damage the radial artery here, the hand would completely lose its blood supply. On the right, though, we see a positive test. The released ulnar artery immediately flushes the palm pink. The anastomosis and the superficial palmar arch is working beautifully. And that brings our anatomical journey to an end. But before I let you go, I want to leave you with this provocative thought. If a patient's Allen test is negative for both the radial and ulnar arteries, what alternative, maybe deeper anatomical pathways could potentially save the hand from complete necrosis? And more importantly, how would you clinically detect them at the bedside? Ponder on that deeper vascular anatomy, Justin. Keep studying smart, keep those concepts crystal clear in your mind, and I will see you in the next explainer.